My assignment is within 15 minutes to try to explain primary care so that everybody understands it. And I don't normally do that in 15 minutes. But I don't talk like a doctor, so at least you don't have to worry about all those acronyms and everything else because I can't remember any of them anymore. So what's going to happen to primary care? First off, put it in context. Several fascinating, fairly recent studies. If you look at every state in the country and compare the states that have a large number of primary care doctors to the ones that have a small number of primary care doctors, you see that the states with a lot of primary care have a lower mortality rate, better self-reported health. In other words, there's some measures that say, gee, those primary care doctors make a difference around here. If you go a little further than that, and there's a whole list of all the attributes of a good primary care practice, continuity of care, aggressively using evidence-based medicine, focusing on all the problems, looking at prevention along with just treatment. If you compare the practices that score high, you find that the patients there also have fewer emergency room visits, better preventive care, and report being healthier. Now, the recent data that I found fascinating is somebody looked at all the Medicare regions and categorized them into quintiles. If you look at the regions that have the highest number of primary care doctors compared to the ones with the lowest numbers, you see a significant difference, a 5% lower mortality rate, 9% fewer hospitalizations. But the other interesting thing in this study is there wasn't a lot of cost savings. I mean, you can keep them out of the hospital, but it doesn't mean that good primary care is dirt cheap. Now, the other way of looking at it, well, we're going to look at something else. It's one of those afternoons, you know. I've had my sugar high after talking about obesity this morning. In America, about 32% of all the physicians are primary care, and that includes general internal medicine, family medicine, and pediatrics. In most countries on this planet, it's about 50%. In Great Britain, 80% of the physicians are in primary care. So we are a very specially laden society, and until recently, just kind of marginalized the primary care physicians. Taking a look at supply and demand, another important thing, seniors, those 65 and over, require about 75% more services from a primary care practice than those under the age of 65. So guess what's happening in America? The baby boomers are getting old. I hate to tell you that. I suppose some of you haven't figured that out yet. It'll creep up on you, but when you get to be about 80 or 90, you'll decide that maybe I am getting old. So as we age, there's going to be a lot more demand for all kinds of health care, especially primary care. Accountable Care Act. From my simple view, the big thing the Accountable Care Act did is it finally said, we've got to make access to health care available for Americans. And they did all kinds of things to try to achieve that. Basically, they're trying to get about 32 million more people health care coverage. And if all these people come into the system, there's going to be a significant demand, especially for primary care. Now, here's something that'll blow you away. The number keeps changing. It's about 144 million. 144 million American adults have at least one chronic disease. Half of Medicare recipients have 5 or more chronic diseases. In America, we do a great job of keeping you alive with chronic diseases, and it's called industrial strength medicine. It is incredibly expensive. So when we take a look at this, it means there's going to be a lot of demand for primary care, especially if you have a system that works the way it really ought to work. So the family physicians say, we're going to need about 45,000 more by 2020. If you look at the physician shortage overall, the numbers bounce all over, but maybe 60,000 more physicians to take care of the things that I just showed you. The good news is that we're opening a few more medical schools. and medical school enrollments have been increasing. So we're going to gradually ramp up first-year medical students about 16%. Oops, 30%. That's even better. Interestingly enough, the mood is changing. More people are choosing primary care residencies than a few years ago, and fewer people are choosing radiology residencies and things like that. So the marketplace is changing things. Physician's assistants, they say that their numbers have increased 200% over the last decade. Looking at nurse practitioners, the projection is, maybe it's the hope that we're going to have about 23% more in the next 10 years. And if you want to be innovative, there's a lot of other ways that you can use personnel to support the provision of primary care. So on the one hand, the demand is going way up. We're way behind the 8 ball in having a robust primary care system to begin with, but we're seeing some things turning around. Now, the reality is called time. And you think about what does it take for somebody entering college to coming out and hanging a shingle, you're looking at around 10 years or more. And so even though things are improving, it's going to take a very long time before we're going to turn our manpower requirements, our supply rather, around. And that means that we're going to have to be innovative. We're going to have to figure out better ways of practicing medicine. So good news, but let's face it, in America, for most things to change, it takes god-awful long. Now, the next thing we need to talk about a little bit is what do we want? What are we trying to create here? There's something that's been about at least 10 years now called the Triple Aim, created by Donald Berwick and the people of the Institute of Medicine, and now obviously very important to the Institute for Healthcare Improvement. When I think about it, I cannot think of anything important in medicine that doesn't fit in one of these 3 categories. This is probably the most important slide I'm going to show you, because if you're ever trying to figure out what do we do about healthcare in our state, one of the lenses I would look at is, does it fit here? So what are these magic things? First thing is population health. In other words, what are we doing about the entire population in a community or in the state? What are we doing to try to prevent diseases? Proactively addressing things before they become a problem. So, not very well done, but critically important. Second thing they call the experience of care. Patient-centered care. It's safe, it's friendly, it's responsive, it's timely, all those magic words we'd love to see. But there's some other things which are critically important, and it just sounds kind of like an aha. Here it is. Do the right thing well. See, about 30% of everything we spend in medicine is wasted. Unnecessary care, sometimes even harmful care. There's a lot of stuff we do that the evidence doesn't show is very beneficial. Do it to the wrong people. The other thing is, if you look at the Medicare population, there might be as many as about 180,000 Medicare patients dying in our hospitals every year from medical errors. So it's not only doing the things which are actually going to benefit the patient, but make sure that we do it right the first time without problems. Third thing, which is sort of the most challenging, is per capita cost. And that basically means that you're trying to create value. You're doing the things that work well. You're not doing the things that don't work. In other words, eliminating waste and the unwarranted variation. But you've got to look at the entire patient and the entire cost of care. There's a lot of things you can do that are cheap, but over the long run, it may be better to, for instance, with what I told you this morning, it's probably better to spend money on prevention early on than pay for diabetes later on. So you got to look at it from a sort of a systems approach. Now, there's a blank over there, and I don't like blanks. There is another thing which is critically important for American healthcare, and it's something that we've never dealt with. It's something that we do not want to touch. It's the third rail in our minds, and it's called, Why don't we have a discussion amongst the stakeholders like the American public, the healthcare industry, and everybody else, and try to decide, come to some kind of a consensus about, so what are we entitled to? Who's going to pay for it? What are my individual responsibilities? How much should I pay out of pocket? How do I balance what I spend in healthcare in my state with what I spend on education and prisons and all those other things that you struggle with? In the past, we didn't think we had to deal with them. If you look at your budget, it's a zero-sum game. There's only so much money. You can't keep piling it into an entitlement that somebody thinks they deserve. But we've never had an honest discussion. We've never gotten to a consensus. We've never gotten the two political parties to come to any agreement. It's all smoke and mirrors, and let's avoid the issue. And we cannot afford that anymore. Okay, the next slide that's worthwhile is this one. This is the future of healthcare. We call it the patient-centered medical home. People think that that must mean that I'm going to a nursing home. I like to call it a patient-centered health home. An accountable team leader, in other words, somebody who actually feels responsible for your care. It's got to be a collaborative team of individuals using evidence-based medicine working together. Everybody's got different skills. The family physician is very good at some things, probably doesn't have the time and maybe the people skills and the patients to sit down and explain a lot of complex things that the patient's struggling with. There's got to be a focus on all aspects. It's not I'm the liver person, it's I'm taking care of the whole person. I'm not taking care of the diseases I know, I'm taking care of all the health issues of this person. A lot of monitoring and support all tied together by an electronic health record. It's patient-centered. It's sensitive to patients' needs, ethnic groups and things like that. A lot of education, coaching, navigation, shared decision-making. Because we're trying to empower the patient to take more responsibility for her care. Lifelong continuity. It's not, for a guy after their last tetanus shot, they don't come back in until they break something or cut something. And by that time, you discover they got diabetes and high blood pressure. There's got to be easy access to care 24 hours a day, 7 days a week. It's easy to do if you want to change. You can have emails, you can have telephone consultations or video consultations. If you can't provide it, let them go to the Minute Clinic at night. Let's make it so that it's easily accessible. It's got to be part of a system because you need all the specialty support at various times. And you've got to have a payment system that incentivizes creating health, not just creating widgets. So it's a very complicated change. Everything is designed to prevent disease, to effectively manage it, to really meet the patient's needs, and to control resources at the same time. For those of you who know about healthcare, you know this is incredibly hard to create. This changes every paradigm we've ever believed in. You mean I get paid for not doing things rather than get paid for doing things? You mean I got to work with other people? I've got to figure out relationships when none of us belong to the same organization? We've got to agree upon what we're going to do. See, the trick is you got to have only the right people on that team, and they only do what's necessary. You can do more, but you're not going to make any money doing that. And that means you really have to think about how this is going to be done. And if you make all this work, now you got to train your patients to be able to effectively use this kind of a system. Okay, another slide that's important because I talked about population health. It's complicated also. And I went across this morning. But basically, you start with a pretty amazing human being, and your goal is to have a thriving individual as your society. Unfortunately, a lot of things get in the way. The environment that we live in, the social determinants of health, whether we encourage people to live healthy behaviors or not, decides how much disease you create, how much you have to use your healthcare system. And all this here, all tied together, decides whether you're healthy and functioning well or whether you've got disabilities, a lot of pain and suffering, and die 15 years prematurely. So there's the map. Healthcare traditionally, once you get sick, deals with it, but more and more we've got to deal at the pre-disease stage. Let's identify high blood pressure, high cholesterol, poor habits, and try to get them to change. But if you really want to have a healthy community, you've got to go back way beyond that, and you've got to deal with the built environment, the social determinants of health, the school system, the workplace, all of these factors which are either making us healthier or making us sicker. A couple other things real quickly changing. Yeah.
You got your hook?
Science is changing it all. We're getting more and more self-use biomonitoring. It can get downloaded into your cell phone or whatever, populate your personal health record. You can go online and get more and more support. Maybe we'll all have an avatar to help us manage, our health coach. Excellent sites like D-Life for Diabetes, Patients Like Me, social networks to help people manage their health. More and more ways of using virtual care for people that are empowered with this stuff, tied to monitoring and support from your healthcare system. And we're slowly getting into auto care where we can implant something that's going to monitor your body and give you the medicine that you need. So the technologies are giving us the ability to do more and more individualized self-management with various support. The other thing is that biotechnology is giving us so much information now that we're rapidly getting to the point where with simple biomonitoring devices, we can look to see if you got cancer cells floating in your blood. For $1,000, we can map your genome. We can take a look at the proteins to find out if pre-diseases are operating. And some of these things, that's a tattoo, which is a biosensor. We're learning how to test things with saliva, breathalyzers, simple stuff like that. And imagine if you've got a real-time virtual map of what's going on, from the cloud of, this is your health status. This is what's going on with your blood sugar and your blood pressure. And of course, all this data can really be turned into knowledge if we start accumulating it. So that means that more and more we're going to be able to predict somebody's risks. And with that, if we're smart, we're going to do something about it, rather than just say, gee, that's really too bad. That means that we've got to do preventive medicine. We've got to try to get people to change. It's got to be personalized to the individual. It's got to be participatory between the patient and the healthcare system, get the family and other people involved. And more, because this is moving upstream, we're going to be taking care of pre-disease. Why wait till you have symptomatic cancer or diabetes or whatever? Let's identify the earliest changes and make the difference to try to prevent the disease in the first place. Which means that we have to change our focus so that more and more we're going to focus not on how do we use the industrial strength stuff to hammer a disease. How can we help the body to stay healthy and to address these things early? So that's kind of where we're really hitting big time in primary care.